Thank you so much for coming on the show. It's great to finally meet you nowadays. Meet you today. It's how we meet each other over Zoom, right? In person. So why don't you tell us a little bit about yourself and your organization and what you're passionate about?
That's right, Chris. It's really a pleasure meeting you. Thank you for having me. And I'm, of course, a vivid fan of your show, and it's nice to be on.
Oh, thank you. Thank you.
Good. My background is in machine learning. I have a PhD in machine learning. So we are doing machine learning and AI for healthcare for a long time. What I'm specifically doing is we are working at a company we founded in 2017 called Paige Pathology Artificial Intelligence Guidance Engine.
Oh, nice.
Yes, on AI that helps pathologists to diagnose cancer patients better, faster, in new ways, helps oncologists to find better treatment for patients, and helps patients to get their answers faster and get the right treatment at the right time.
Oh, fantastic. So one of the things I've always thought was that AI could do everything because it had access to immense amounts of data that we as human beings can barely comprehend. Is that part of what's happening in your solution? I mean, can you tell us a little bit more about it?
That's certainly part. So what machine learning and these new deep learning models over the last few years and now transformer models give us are actually new statistical tools to just capture more structure, more patterns in data at scale. And the same is, of course, true in healthcare and especially also in cancer care and in pathology. And that's what we do. So I started working in that field nearly 20 years ago. In 2000.
Oh, you mean AI hasn't been around from just last year? Because that's what it feels like sometimes. It's like
that's right. It's only in the public consciousness since last year, but yeah, it's around since half a century to some degree. That does not minimize the breakthroughs of recent years, of course. That's beautiful, and we take full advantage of that also in healthcare. So at Paige, we one of the main modalities we are working with are microscope slides. So let's say if you have a biopsy, a prostate biopsy, a breast biopsy. So these are needle biopsies where part of the tissue, part of the tumor are taken out, and then they can be analyzed under the microscope on these glass slides. And these days you can actually digitize these slides and you end up with humongous images. So they are 100,000 pixels times 50,000
wow.
pixels. So they could keep all the holiday snaps into just one of these slides. And if you have a prostate biopsy, there are multiple needles, multiple slides. So you could have dozens of these, and in breast even more, or in skin maybe one. In all these cases, what pathologists need to do is look for the needle in the haystack. So the cancer lesions could be tiny. Hopefully they are still tiny. You have an early detection, and finding these are difficult. And that's something AI is actually very good at, especially if in our case, you train these models from tens of thousands or 100,000 slides, so millions and millions of images to actually find cancer early so you can treat it earlier.
So there's no possible way a human being could do this. It's just sheer volume of data that it's chunking through to find these lesions.
Yeah, these days in pathology, so in vast parts of pathology, even in the US, actually the practice has not changed in 150 years. It's still analog in most places, and we are just in the midst of that revolution that pathology is going digital, and there's a number of large lab networks or academic medical centers and a number of community clinics as well that go digital, so they can actually have pathologists work remotely, and you can take advantage of AI. And so it's still a very human task, but that means it's also very subjective. And what we could show at Paige, where we actually went through the FDA with one of our systems, that Paige could reduce the error rate by 70%.
Wow, fantastic. That's amazing.
Yeah, without additional false positives. And I think that's one of the great promises of AI, of course, in healthcare, that you truly can improve care. And if you think in the US, you have 800,000 patients every year that either die or are permanently disabled because of malpractice or treatment errors. And many of these can be caught by AI, as we demonstrated, for example, in prostate cancer. So the impact AI can have on well-being of patients is very clear, and we have to do whatever we can to actually get more AI into the clinic, not less.
Oh, absolutely. I mean, you keep hearing all these horror stories about all the horrible things that AI is doing, but underneath the radar, there's all this good stuff that's going on, but we never seem to hear about that. We always seem to hear about all the negative things that are going on.
Right. I mean, because I'm also, of course, a science fiction fan since a teenager, and it's much more fun to read dystopian stories and watch Terminator movies. Where I'm actually from the same town as Arnold Schwarzenegger, so that's where
Oh,
the
wow, cool.
in Austria. So that,
Is there
of
like a
course,
statue of him or something like that in the town? Or
maybe at home, yes. So that, of course, triggers human imagination, because that really hits home in these science fiction tropes, and it's easy to think that way. But practically, these are tools, right? They will certainly transform our societies, transform how we learn, how we teach, how we work. But most of that will be in a very, very positive way, and we have to control the risks. And especially in healthcare, again, I'm saying that over and over again, people are dying not because of AI, but because of a lack of AI.
Right, right. So I'm assuming that you're also discovering new things that lead to particular conditions as well that we couldn't do before because we just didn't have the ability to process as much as we are.
Right. I think that's one of the most exciting areas. So you can actually go beyond what humans can do today. You can not only help physicians to be faster, more reproducible, and so forth, but you can also do new things. For example, if you think about genetic changes, or in our case, these are somatic changes of the tumor. So if you have mutation of a gene that actually triggers the tumor, that goes then to proteins and to translate it to really the growth of the tumor. So the way cancer looks like, right, the way it grows, the vessels grow, tell you about the underlying molecular changes. And in some cases, you can really train AI models to look at an image and then say with high accuracy, this is an EGFR mutation or an FGFR mutation. And that's especially important because some of these mutations can be targeted by drugs. So if a tumor is driven by the drug, for example, in lung cancer, you have very specialized drugs that you can treat these kinds of cancers. And that, of course, has great impact on the patient. And even in the US, and especially across the globe, not everybody can afford expensive sequencing workup in some elite institution. But if you can do it from an image, at point of care, from a diagnostic image that's always taken, then you can provide that benefit really to everyone in community clinics, in rural areas, and across the globe. So it's a good example how AI can democratize access to healthcare and even reduce costs.
Well, I love this concept of you're saying that the higher resolution imagery allows AI to look at things more deeply, because if we didn't have that higher resolution imagery, would we be able to see some of these things as early as we're seeing them?
Right. So it's when I started in that field, the resolution was so bad, so it couldn't compete with a standard microscope. So you couldn't see that much. But these days, the resolution is huge. And also a big change is that with modern AI, so really in recent years with transformer models and attention models, we can build ever larger models and capture more patterns, more connection between tumor types and tissue and so forth. For example, what we do at Paige now together with Microsoft is to build foundation models. And these are dramatically large. So we published one that's based on 1.5 million slides. So these are billions and billions of images. Just as comparison, if you think of Netflix, all the Netflix shows, all the Netflix movies, every pixel of every Netflix show, you have approximately only a third of the data we used to train the current model.
Oh, wow.
And next year,
Fantastic.
we're going to train one with 4 million slides. So that's nearly exactly 10 times more data than all of Netflix. And you see at that scale, you have computer vision models based on 50 billion images that go far beyond the state of the art. But at that point, you now have AI that understands cancer and normal tissue so well and can describe it in mathematical terms in such minute detail that you can use these models on very small data set to hit the ground running. So the same way you would use ChatGPT in low shot or few shot learning approaches, because the model understands language well, we are building the foundation model for the microscopic world. And we want to go, for example, in cancer beyond just the big cancers, prostate, breast, lung, and really address the rare cancers. 50% of cancers are rare, and there are even less tools out there for all of these. So imagine you would have AI support for really every patient, every pathologist, every case. That's the vision we are working towards.
Wow. When you have that sort, is it easier to treat the rarer cancers or the more common ones?
So usually you have more option, of course, for the common ones. And there is also more research that goes in the common ones. Think of large patient organizations for breast cancer, for example, also prostate and lung. And that's very often, of course, missing for rarer ones.
Mm-hmm.
But again, 50% of cancers are rare cancers, right? Because the tail is so long. So
Right.
if you're diagnosed with cancer, it's a coin flip if you have one of the big ones where you have more options or one of the rare ones. Nevertheless, if, as we discussed just before, Chris, if the cancer is driven by a specific mutation, then very often you can use drugs cross cancers because it's the mutation that drives it and not the cancer type. And that's why applying AI to every slide, to every case would have such a big impact.
So the cancer itself attacks different areas, but that means it's a different kind of cancer as well, or are they very similar?
Let's have a more concrete example. Unfortunately, a personal one, for example, from my father is if you have cholangiocarcinoma, which is a very rare one, right? There are very few drugs. You would use standard chemotherapy, and if that fails, you're usually out of luck. But if you find a mutation, in that case, it was TSC2, so it's part of the mTOR pathway. There are actually drugs that are approved for other cancer types, and then you can get them sometimes for compassionate use for these rare cancers, and that worked at least for nearly 1 year, and that's a good example. And you would never know that if you couldn't sequence the patient, which is still rarely done, or you would run, as we are building now, then AI even much cheaper from the image. So yes, if the cancer is driven specifically by a driver mutation where you have a drug, then that's true, and that's true for many cancer types. But it's, of course, cancer is very diverse, and it's hard to make generalized statements.
Mm-hmm, mm-hmm. And then this doesn't go back to sort of like the reasoning. It's just sort of like treating the cancer after it's already occurred, or detecting it early.
Yeah, so what we discussed now was treating the cancer. Early detection is, of course, always beneficiary. And as we saw in the past, for example, the introduction of PSA tests for men in blood, PSA in blood, led to many more biopsies because you saw increasing PSA. So more workload for the pathologist again. That also, of course, if it's so much more, sometimes leads to less accuracy. So you need then AI to help there. What we see now with liquid biopsies, so sequencing of blood, for example, for hopefully early detection, will also lead then to more biopsies, because you would never treat the patient actually without really knowing what cancer it is.
Right.
And then again, AI gives you the benefit. If you see something in blood, you take a biopsy, that you really know what it is and where it is. And as the FDA studies showed on Paige, these tools do truly help physicians to be much more sensitive than they were before.
And these records will all go into, it's like every time you do a scan in a biopsy, these records go into the model to help inform things later on as well, right? So everything just grows and grows and grows.
Yes, but for regulatory purposes, these models are actually locked down when they go through the regulatory process. So for example, the FDA models, these are fixed, they are deterministic, so you will always get the same results, and they are not learning online, right? Or continuously, because otherwise these models could drift, right? Let's say you have
Or like hallucinations.
that as well, right? Or they're just used in the wrong way over and over again, then they would drift. So it's actually good to lock them down. But the FDA also has mechanisms to update these. Right? So we, for example, now with that very large foundation model, which is actually named in honor for Rudolf Virchow, the father of modern pathology, the Virchow 1 model, Paige V1. So the V1 model already shows improved performance on a lot of clinical tasks. So at one point, you would then update the clinical FDA models, and you can do that, let's say, once per year. There are mechanisms to do that. But continuous learning on a daily basis, I think, is not the right way for clinical applications.
Not yet, at least.
Yeah, the thing is,
who decides what goes into the model, though? That's the question. I mean, it's kind of like one of the things about ChatGPT and other systems hallucinating is that, you know, if you feed the wrong data into the model, how do you decide what data needs to go into the model?
yes, exactly. So in our case, or in Paige's case, so Paige is a spin out of Memorial Sloan Kettering, and Paige helped Memorial to digitize the whole archive. And then we have also the links to report. And the FDA recognized the final report as MSK as ground truth, because it's not just a slide, but if it's a difficult case, pathologists pull in other pathologists, or the additional tests, genetic tests, immunohistochemistry tests, and so forth, and then you have the final report. But you're right, if you don't have access to that, then very often these results are subjective. So you have to be careful what goes in.
So you haven't made any diagnoses. AI itself hasn't really made any diagnoses. It's just basically presented the data to the pathologist, and they go, oh, based on what we see here, we believe you have XYZ, right? So it is a human AI combination.
Right, that's an important point. So there are no autonomous systems in medicine at this point that make the complete diagnosis. So you can really see them as additional tests. So a pathologist can order blood tests, again, immunohistochemistry tests, all kinds of different tests, and AI is just another test that actually runs on it. But that also means if you go through the regulatory process in the US or in Europe, you have to have guarantees for the test. So sensitivity, specificity, and that is important. And the FDA, of course, tests in these large studies, and it took us 2 years to design the study and then execute, that these models are safe, effective, and equitable. So regulation is certainly key in medicine, and the AI models should be regulated, even if they are just support models. But pathologists or physicians and patients want to rely on it, and you have to differentiate between that huge hype, right? You have 14,000 biotechs and all kinds of newspaper articles that AI will solve cancer and every disease. And then
when's that going to happen? No, I mean, but I mean, don't you think that's holding things back a bit, though, to always have to have that human in the mix? I mean, wouldn't it speed things up if we could? But I guess we have to trust the AI, and we still don't trust it yet.
Yeah, so there are, trust is one aspect, of course, that comes with, first of all, meticulous testing and studies and so forth, and with practical experience. So, for example, in breast cancer, pathologists trust Paige a lot, especially for looking for metastasis in lymph nodes, which is really a very time-consuming task. And a good pathologist is always anxious and unsure that they missed something. So they go home with that bad feeling, did I really see everything or did I miss something? Because they completely changed the treatment paradigm for that patient. And Paige is so sensitive and so specific that the proof, more or less, that it's negative, right, is so much stronger if you have that second pair of eyes and the AI really checked every single cell, and that helps pathologists a lot. So the trust there is certainly there. But then there's also the aspect that there are, of course, not enough pathologists, not even in the US, to just keep the standard of care. So, of course, there are some tasks that should be offloaded to the AI, very repetitive tasks. And if you think a little bit further into the future, just a few years, maybe 5 years or so, yes, some of the tasks could be offloaded, the screening tasks, right? We already do that, for example, for cervix cancer screening since a decade. There are tools that are by far not as good as the AI tools we develop these days, but they were good enough to actually automate that screening. There are not enough pathologists by far to actually look at all the negative cervix cancer screening tests, right? And the same at one point will certainly be the case for a lot of the biopsies, right, where you can guarantee through testing and regulation that you really capture all positive cases, but a human doesn't really have to look at every single negative case.
Well, so if that's going to be the case in 5 years, let's talk about 10 years out, or it's time to think like a futurist. It's the year 2033. Are we going to have, so have you seen those new booths that Forward, that company is thinking about putting in malls, where you can walk in and it gets a full, does almost a full diagnosis, and then you can walk out? And do you think we'll get to that point within 10 years where we have AI doing a full diagnosis and make it stick?
So I certainly hope so, and we're gonna try to do that wherever we can. And in some areas that will be the case. So a good example is now on the academic side at Mount Sinai. At Mount Sinai, we now have also a center for AI in ophthalmology, so eye diseases, with the New York Eye and Ear Clinic, which is part of Mount Sinai. And there, the plan is to really have a retina scan in every primary care physician office, right? So you do your blood pressure, your weight, and you have a scan of your retina, which can indicate not only diabetes, but all kinds of vascular diseases. There are a lot of work that the AI can even predict neurodegenerative diseases, early onset. So there's so much to be captured. And if you expand that to other modalities, for example, wearables, of course, where Mount Sinai is working a lot, or other disciplines, you get a much more holistic view of the patient. And then you have these AI outputs from all of these. So I'm always talking about a fabric of AI services where you link that all together. You're going to get a more holistic view of the patient. All of that, of course, in a setting where we always have to prove out it's safe, effective, and equitable for everyone.
But the more data you have, the more patterns you can catch, right? Because you could say, I could go into this clinic today and upload my data, and then 2 weeks from now, it could use my data to diagnose somebody else, and then come back to me and say, hey, by the way, you have all the markers for XYZ. I mean, I'm assuming if it has all the data, it can see the patterns that we wouldn't be able to see because we'd have to sift through so much data. How far away is that?
Yes, agreed. So most of nearly actually all of the AIs that are applied these days in healthcare that are approved are narrow AI. So these are very specific solutions, either for pathology, for EKGs, for ultrasound, and so forth, right? They're not linked together in genetic ones. So what certainly is a big push of our research, and also where Paige is going, is that you have multimodal systems. So you link radiology, pathology, genetics, variables, all of that together to make a better decision. There, of course, you again data limited, because you most of the time don't have all the data for patients, but only the separate ones, and there are different ways how you would come to a joint image. But that's certainly where we're going. And you also write about complexity, right? So as humans, we always have the desire to have some level of explainability, so we get the feeling we understand what's going on. But if you now go, let's say, 20 years into the future, we will certainly, and hopefully actually, have AI that goes beyond our human capabilities. When my loved one is sick, I want to have the best possible diagnosis. And I don't care if the physician, the nurse, the technician, or myself understand every detail. I want a system that's proven to be safe, effective, and equitable, but that hopefully can make connections between complex interactions between genes and proteins and morphology and macro presentation and timeline that goes far beyond what we humans can do. But that certainly will be a process. But I think it's truly a moral obligation to develop AI in medicine as fast as we can, as good
Absolutely.
as we can, as safe as we can.
Well, so I cannot wait for an AI doctor, because that it's not like you're talking to a single individual with the brain of a one person. You're talking to a legion of doctors, thousands, millions of doctors, all at the same time when you're speaking to AI. I mean, that's, if you ask me, that's much better than having an individual person. You're like, oh, that's inhumane, but it's like, it's still us. It's human beings. It's the knowledge of human beings in this device repeated back to us in a much more intelligent way. So
yeah, absolutely. And it's actually not only for the benefit of the patient, but also for the benefit of physicians, right? It's something we shouldn't forget. We do not have enough physicians. So there are, for example, the cancer cases go up, the complexity goes up, the number of pathologists goes down. So there are the positions for residency can't be filled even for, or fellowships for pathologists these days. So that gap always increases. So just to keep the standard of care, you're going to need AI. And then as a result of that, physicians are burned out, nurses are burned out, right? And tools like also in primary care, for example, voice recognition that automatically transcribe everything that's said and the report is generated automatically, helps physicians to save a lot of time. They don't have to sit in front of their PC while the patient is in the room, or at 10 at night, and write the report. So it makes their life much easier. Also, of course, the nearly all physicians I know want to take any tool they can get their hands on to give better care. And AI just provides these tools to really make human physicians superhuman.
Yeah. It's better for everybody all the way around. It's a good thing.
Yes, in healthcare, it's utterly a good thing, and it's easy to make that argument, and people often forget that. Right? So there are, of course, if you think in these doomsday cults these days, there are calls for just to stop all of research because of some off chance something could go wrong somewhere. The fallout of these calls is real. Right? If you would stop developing AI in healthcare, people are dying, patients are dying.
Exactly.
And that's just for a hypothetical. I don't think that's a good idea.
Absolutely. Well, this has been fascinating. Thank you so much. If someone wants to get in touch with you, what's the best way?
So for Paige, you can just go to paige.ai and you see a lot what's going on. If you want to get in contact with me, so I'm on the Paige website or at Mount Sinai for academic purposes. Happy to chat with everyone. And again, Chris, thank you for the engaging conversation and the invitation.
Well, thank you so much for coming on. Talk to you soon. Thanks.
Thank you.
Bye.